Hello and welcome to tonight's episode of the Rural Doctors Programme. I'm Jerry Gannon. Thanks once again for your company. Well, tonight our programme will focus on viral infections. Dr. Paul Armstrong and Dr. David Smith from the Communicable Disease Control Directorate give us an update on the H1n1 virus, as well as discuss other potentially nasty viruses to look out for as we head into the cold and flu season. But before we chat to them, we'd like to thank those of you who attended the annual conference. It was fantastic to see you all there again this year. While we were at the conference, we caught up with Belinda Bailey, the CEO of Rural Health West, and Belinda gave us a quick update on what Rural Health West is up to in the coming year.
I'd like to say a great big thank you to everyone that's been involved with the annual Rural Health Conference this year. Everyone that's been involved and who's actually attended. Because we know at Rural Health it's a big deal for you guys to be leaving your practices and your homes over the weekend to come to the Perth conference. So a great big thank you to all that's been here. As you know, the Rural Health West annual conference in Perth is just one of the conferences that we run throughout the year, and we've got a number of conferences coming up throughout 2010, and I'd really encourage you to get on our website and have a look at those. While you're there, of course, you should also have a little look at the other educational programs that Rural Health West has been planning for the benefit of rural and remote general practitioners. We've got a whole range of procedural workshops that are both going to come to you at your place, and also procedural workshops that we'll be running down here in Perth. So again, all that information should be on our website, and I'd encourage you to go there. The other thing that's really exciting for Rural Health West this year is that we're developing a remote retrieval emergency workshop up in the Pilbara for later this year. It's a new thing for us, and we're hoping it's going to be fantastic. Please go on to our website, have a look, see if it's something that interests you, and let some of our staff know if you're keen to be involved. Again, on behalf of all the staff of Rural Health West, if you've been at this conference, thank you. If you're coming to our next conference, that's going to be fantastic, and we'll look forward to seeing you there.
Rural Health West CEO Belinda Bailey there at the annual conference, and thanks again to everybody who attended. Now let's join Olga and the panel as they discuss viral infections.
Could we start by talking about pandemic influenza? Hugely topical, particularly at the moment when we're vaccinating patients again. Why did the swine flu spread and behave the way it did?
Look, I think what we saw was something we'd been preparing for a long time, which is this appearance of a new strain of influenza, which was, if not completely different, very different from any of the strains that were currently circulating. And when that happens, it always behaves differently. Now, we call it swine influenza, which is a little unfair to the pigs because, in fact, though it has components of influenza that's found in pigs, it has components that were found in birds and in humans. Mm-hmm. And in fact, the disease that occasionally occurs in pigs is where pigs get it from people. So, so pandemic influenza is the politically correct way, but we all understand when we talk about swine influenza. What happens when a new strain emerges is that because there's very little, if any, pre-existing immunity in human populations, it can spread unabated. So that whereas with seasons there's always a bit of carryover immunity. The last year people who've been exposed or vaccinated have got a bit of carryover immunity. So it just damps things down. It doesn't stop it, but it damps things down. If you haven't got that, then it just takes off. And there are a few characteristics that happen then, which we saw with this one. One is that you tend to get very rapid spread. And we saw that from the very early cases described in Mexico and in the south of the US, cases began popping up in lots of other places around the world very quickly, linked to where the planes went, and then it spread just like wildfire. The second thing that happens is it tends not to behave as strictly as seasonal flu does in respecting coming in the cold weather. And indeed, that's what we saw, particularly in the Northern Hemisphere. It appeared outside their normal influenza season. So those two patterns, characteristics are often seen in emergence of these new strains. What was different was that unlike seasonal flu, the elderly were relatively spared. And it's probably because if you'd been around long enough, if you were 70 years or so old, you'd seen enough of the very distant strains of H1 influenza, the ones that had been circulating in the 30s, And those ones gave you a bit of protection against the current
strain. So it's actually
strain.
nothing to do with the fact that we've been flu vaccinating our oldies for the last 10 years?
Well, look, it's likely the more exposures you've had and the more influenza vaccinations you've had over a longer period of time, the more likely you were to have some protection against this strain. But we know that the recent influenza vaccines, the H1 strain, didn't protect against this virus, nor did having natural infection with the recent influenza H1 strains give protection, and that's why we saw the patterns of disease that we did in 2009.
So it's a characteristic of this particular virus that made it spread so rapidly, or just because it was brand new?
Yeah. But what we've seen so far is that the transmissibility of the virus is pretty similar to seasonal influenza. It might be a bit different, but not dramatically different, and the rates of spread have been very similar. So it's probably more to do with the fact that just it was a new virus. But you might want to comment on the data on spread in the community.
No, I think it has behaved quite similar to, in its transmission dynamics, to other seasonal influenza strains. But as David said, a feature of a pandemic virus is one that comes about when the population is naive to it. So everybody is susceptible to it, except for, in this particular case, the people above a certain age. So everybody's susceptible, and it does spread quite widely through the community and fairly rapidly. One of the other differences, of course, in the behaviour of this virus compared to previous pandemic viruses is the severity of it, and that's been the topic of a lot of discussion. And pandemics, we know, vary markedly in their severity, their impact on the community, and that's got to do with a whole lot of factors. But the Spanish influenza pandemic of 1918 was the big one. The mother of all pandemics for the last probably 300 years, and that had around a 2.3% mortality rate around the country, around the world, a bit less in Australia. The more recent pandemics in 1958 and 1967 were much milder, and this causing a far lower mortality rate. And this virus that we were dealing with, or still are dealing with, is much more akin to those milder ones. So we were very lucky in that regard, and all our plans were for much more severe pandemics. We had the Spanish influenza in the back of our minds. We had the H5n1 avian influenza in the back of our mind, which was causing 60% mortality and still is. So we were aiming towards this more severe end of the pandemic spectrum, and I guess in a way it took us a little bit by surprise. The H1n1 so-called swine flu strain was the one that came through as the pandemic strain.
Yeah. So when there is a pandemic, how do you manage the whole population of Australia when you're trying to control a pandemic?
Well, pandemic planning has been going on in a fairly robust way for the last at least 10 years. 1998, 99 was when the first document from the Commonwealth Department of Health and Ageing came out about pandemic preparedness, and there's been a number of iterations of the plans over that time. So learned people have sat around lots of committee meetings for a long period of time now thinking about how best to do it, and part of it is intuition, professional sort of knowledge of how diseases work, and also from experience in past pandemics. So we've got good data from previous pandemics to go on to plan for subsequent ones.
So what are the phases of the plan? You know, when you detect a strain like, you know, piggy flu in Mexico, you think, okay, Fortress Australia. What happens next? What's the next phase?
The way the plans are written in Australia are a number of different phases of the plan, and the first part of that is the so-called delay phase, and that is because we're an island nation and we perhaps have the capacity to keep it out of the country, to have screening at the airports and have certain border protective measures in to prevent it coming in. Once it comes in, the idea then is to contain the virus, to stop its spread as much as you can throughout the community, to buy time to create a vaccine. Now that's the basic idea of it all. And the vaccine, of course, takes several months to produce from go to woe. Yeah. But it takes an enormous amount of effort to quell a virus like an influenza virus for that period of time. In this situation, because it was a milder pandemic than what we might have expected. Those very robust and rigorous public health measures to contain the virus were relaxed because we realised it wasn't causing as much problems as we thought. So then the virus went through the community in the so-called protect phase, which people may have heard about, which was not in the original plans but was thought up through the pandemic, and then into the sustain phase and the control phase. And the control phase is when we have the vaccine at hand and we control the pandemic by vaccinating the whole population, and that was the plan.
Yeah.
And I think I think people should understand with this Fortress Australia, it's not something you're going to keep out of the country.
No.
Not within the modern... Well, it didn't work in 1918 when people came by ship to the country, and it's not going to work in circumstances where you've got so many people entering by air travel and such rapid movement of people. What it's designed to do is to slow that process down, to give you more time to prepare and to get the preventive measures in place, and also to spread the load a bit more, because the more you can spread out the load, the easier it is for a health system to cope with that then.
Now, in the initial phases, we were being advised often to do some testing. What's the process for testing and prioritising patients for testing?
Well, perhaps I can start off by just explaining what the idea was from a pandemic planning point of view, and David can perhaps talk about the laboratory aspects. But the reason for testing people in a pandemic changes as the pandemic progresses. And first up, what we really want to know is when are those first cases in Australia. So it's more like a surveillance tool looking for community transmission. So then you have to cast the net fairly widely and test people who fit a certain case criteria. Yeah. Later on, as the numbers build up, laboratories can't manage the number of testing every single person with those diseases. So then we have to curtail it to those that need testing. So we don't swamp the laboratories with too many samples. So then it's more about when taking the test may change the management of that patient or when a patient's hospitalised.
Yeah, look, I think there are a lot of issues when we look at testing, and in some ways they're no different than any other testing, but really you're trying to deliver the tests where they're going to have the greatest usefulness. Yeah. Paul's talked about the public health aspects in terms of how we use those to inform the public health response, identifying early cases, looking at clusters of disease, looking at entry into new areas. The second important group, of course, are those where it's important in the clinical management of the patients. And that's really looking at prioritising testing to those who are more critically ill. So it's largely hospitalised patients. Yeah. The rest of the testing tends to come down in the third tier, which is where in normal circumstances we'd say, well, if somebody is interested in knowing, they have their reasons, and therefore we would like to deliver that test to them. Mm-hmm. When you have a situation with a very high demand, and I must say, even in our heaviest flu seasons in previous years, our peak demand would have been around 300 tests a week. In 2009, it was over 2,000 tests a week, and sometimes 600 or 700 in a day. Yeah. That's not sustainable if you don't. You want to have a resource that's sustainable, therefore you start looking at how you prioritise testing in discussion with clinical and public health colleagues. And generally that means then you start making sure that those more urgent ones go through quicker. Mm-hmm. And sometimes at one stage, in the end, there were about 6 or 7% of samples which weren't tested because they were in lower priority groups. And the real challenge is how you communicate that, how you get that information out. Because certainly the doctors I spoke to were very understanding, they understood what was happening and they modified their practices according to that. And as long as people understand what you're doing and why you're doing it, they're very supportive to that.
It sounds like there was a pretty robust overall master plan for this. But as a GP on the ground, we were getting operational instructions sometimes 2 and 3 times in a day, often contradictory, and from 1 or 2 with sometimes even 3 different sources, which made it very difficult to know whether we were in a phase where we were supposed to be testing for surveillance or, you know, testing our chemotherapy patients who were just starting to get a fever, or whether we were simply in a phase where we were going to blitz the whole lot of them with Tamiflu. Can you comment on how that kind of communication is managed and where it's managed from?
Communication always comes up in the top 1 or 2 major issues in debriefs from emergencies and disasters and exercises and training for these things. It's always up there. It's a very difficult thing. That idea of some feeling of mix-up in communications, multiple sources of information coming in, has come up a lot in the debriefs, and we surely heard that very loud and clear, and plans are afoot to modify our plans in Western Australia to make sure that doesn't happen in the future. One of the issues, of course, with general practitioners is the Commonwealth feels they have a responsibility in communicating to them because of the fact that they're GPs and they're part of the Medicare, part of a national system, and the state public health and clinicians also want to communicate with them. So, and sometimes the communication is not exactly the same, and that does cause confusion. And then, of course, there's professional bodies who want to put out their information to them, and it's clearly an issue, and it's important, I think, that you've raised that. But one of the tenets of emergency management is to have a single line of communication to the stakeholders, and we have to work harder on that. And I think we've certainly learned a lesson there, and we'll carry it forward.
Yeah, and I think the other thing was it wasn't just at GP level. That was all through the system. We all got at times an information overload, and you try to make sure that people don't. I guess you try to make sure people don't say, "Well, nobody told us," and some people are still saying that. But then try to strike that balance where it's not a flood of information. And particularly at the general practitioner level, the feedback we got was, look, we understand there's a lot of information, but somewhere in there is the bits that we really need to know. So sometimes the information was there, but it was just a bit too buried for most general practitioners to have the time to find it out of there. And it's clear that the information needs to go in that succinct, concise fashion that says, look, this is where we are, this is what you need to do, and hopefully nobody else telling you
today
something
we're up to
different.
containment, and we need to do this.
But the nature of pandemics, as Paul mentioned, we have these plans. The plans are a base and a framework, and they were really useful, but that isn't how things actually happened. They never actually happen exactly the way you think it might, because it's a natural organism. And therefore there is always going to have to be a degree of flexibility. There does have to be a degree of modification of responses. And, you know, the communications at all levels were, you know, twice a day, depending on the stage. And so things were being modified. I don't know that we'll ever eliminate, particularly in those peak phases, the need to be able to modify responses and provide information as new data comes through. You know, in initial phase, it appeared there were very high death rates. And that alters how you manage it compared to the data that came later, showing that in fact that was just a result of how the information had been collected. Yeah.
Now, you were talking about collecting specimens, and one of the things that happened for general practitioners was that a set of personal protective equipment was recommended, which had you dressing up in something that looks a bit like a nuclear disposal suit for taking a swab from a terrified child. It certainly seemed like a bit of overkill, and most of us were quite pragmatic about using it. How necessary is it, and how much pragmatism can one get away with in this sort of case? And what would have happened if it had been more like avian flu?
Well, if it was more like avian flu, I think people would be much more assiduous with wearing the PPE, and that's what the plans were, as I was saying before, were aiming towards, a more severe pandemic. So because this was a mild one, you know, an element of pragmatism clearly came in there. But I mean, from our experience with SARS and our knowledge of the science of the way influenza viruses are spread, wearing a high filtration mask, a P2 mask, and wearing gloves and proper hand hygiene, etc., we know can stop the spread of influenza. In a mild situation like this, well, I mean, if you get influenza, the vast majority of people are going to get well, and then you've got antibodies and you can be protected. You can take that view, but if it was a more severe one, I think that clearly there's more importance placed on that.
I must say that within the hospital setting, we will be maintaining the use of the P2 mask for people who are likely to have close exposure. So really on emergency departments is the people who are dealing directly with cases, particularly if they're having nebulizers or being put onto some of the ventilation support that's going to increase aerosol production. But for more casual contact, surgical masks would be sufficient. Yep. But those are the sort of things that come out of experience. It's very difficult at the beginning to know exactly how things are going to pan out. So you do tend to err on the side of caution, just in case. And you're right, I mean, the GPs were getting their experience and seeing what was happening, and they were exercising a degree of pragmatism about this. If it had been an illness that was causing a lot more severe illness and deaths, I suspect responses would have been different. Now, can I make one other comment? I do want to make it clear when we talk about this being mild, it's mild for a pandemic. It wasn't mild for an influenza season. It was a busy season for lots and lots of people. And one of the standout features was the load on the hospitals and with those people getting severely ill. And it was very different from our normal seasonal experience.
Yeah, we certainly had a lot of country hospitals bulging at the seams with some very ill people.
And the people in were different people. It wasn't the elderly. There's normally an influenza season, the peak of severe illness occurs at the extremes of age, the very young and the elderly. This year the elderly were actually down. 2009 the elderly were actually down. And whilst there was an increase in the young people, the most dramatic change was in the 20 to 60-year-old age group. Yeah. And of course also the identification of severe disease in pregnant women, which were a group that was not a group we recognised as being high risk of more severe disease.
Now, what was it about the virus that made it particularly attack those people?
Look, exactly why pregnancy was an increased risk is still something that's undergoing discussion. We know that a lot of the severe disease that we saw was a straight viral pneumonia, unlike classically with seasonal, you get a secondary bacterial pneumonia. Yeah. You certainly see viral pneumonias, but not very commonly. This was very different. We were seeing a relatively small proportion due to bacterial infections, and the vast majority be the virus directly striking the lungs. Now, why is still an interesting question and something we're trying to understand. With the 1918 strain and with the avian flu, we know that those viruses were much more prone to produce what they've called the cytokine storms. That is, that they induce all these inflammatory mediators that cause the damage to the lungs. And that's a product of a healthy active immune system, and you tend to see that in younger adults more often than at extremes of age. And there may be a component of that with this virus, but it's not a 1918 virus and it's not avian. It doesn't have those same... You
wouldn't expect that huge immune response would happen in a pregnant woman either.
Well, that's right. Now, pregnant women, it might be that there's a degree of relative immune suppression, but this disease, we certainly saw cases of immune compromised. It didn't seem to seek them out. The other thing is, particularly in second and third trimesters, it may be that there's a degree of respiratory compromise associated with that because of the pressure on the diaphragm, and it may be that that also increased the rate of more severe pneumonias in pregnant women. But we know overall pregnancy carried a 5 to 6-fold increased risk of hospitalisation or going into intensive care units. So it's a really important message for this year.
Yeah, I noticed that pregnancy has been added to the indications for flu vax for this year.
That's right. For the first time, pregnant women are on that free list, the eligibility criteria for the free Commonwealth-funded vaccine, and other groups as well are added on to that this year, widening the criteria. So people who have chronic medical conditions but are under 65 are eligible for it, and all Aboriginal people over 15, whereas before it was over 50. But pregnant women are a particularly important group for us, from what David was saying. Although we know pregnant women are hit by seasonal influenza more than non-pregnant women in seasonal influenza, it seemed to be more severe last year. We know that the degree of immunity in pregnant women from natural infection is not as high as others. We know that from the data we've collected. So it's really important that they get vaccinated, and it is a safe thing to do. It's a recommended thing to do. Women in pregnancy, pregnant women should be vaccinated. And the seasonal influenza vaccine will be out at around the 22nd of March. It'll be available for
It's out now.
It's out now, but the sort of a semi-official launch will be then.
Yep.
It's being distributed around the state at the moment and around the country. So it's there, and pregnant women should be encouraged to be vaccinated.
Mm.
And I think also there's data emerged with the seasonal flu vaccines that immunisation of the pregnant woman passes on protection to the neonate in those early months of life. So I think that's also important in terms of what you can offer to the child born during a period of influenza activity, particularly when you've got new strains circulating, to which mothers are unlikely to have pre-existing immunity.
Fabulous. We might just take a little break there and come back to this discussion in a minute.
Dr. Paul Armstrong and Dr. David Smith from the Communicable Disease Control Directorate there with Olga Ward, and we'll return to that discussion in a moment. The current triennium for CPD points will come to an end this year. To tell you how to make sure you've met all your requirements and received the points you should have, we spoke with Beth McEwen from the Royal Australian College of GPs.
The GP point requirements for this current CPD triennium, GPs need to accrue 130 CPD points. Of those points, they need to do 2 Category 1 activities and 1 CPR module. Category 1 activities are those which are typically about 6 hours in duration and quite interactive and hands-on for the GP. Category 1 activities also include a pre and a post activity. Other Category 1 activities include supervised clinical attachments and small group learning cycles, which continue to be a favourite with our rural GPs. Organisations such as Red Cross, Perth Lifesaving and St John's Ambulance offer RACGP accredited CPR courses. Remember, if you do complete one of these courses, you do need to send us through a copy of your certificate so we can allocate the points to your credit point statement. Other organisations such as Rural Health West offer CPR training in their annual conferences. To save on our trees, the college is no longer sending out paper-based credit point statements. To view your statement, simply log on to the college website and you can access your statement at any time. For those GPs who still prefer a paper-based statement, please get in touch with us and we can organise to send you one a couple of times a year. Remember, if you don't know your login details to the website, of course get in touch with us and we can let you know those too. Some GPs attend activities that might not have been pre-approved for CPD points. In these instances, you can apply for the points on your own behalf. If you attend an activity that was less than 6 hours and quite didactic in style, you can self-apply for the Category 2 points on the college website. Simply log into the website, go to the online services and go to self-record my activities. You can self-record any unaccredited activities that you've attended and you can use this logbook for up to 10 hours. If you attend an activity that was more than 6 hours and it was quite interactive in style, remember you can apply for the Category 1 points via the individual active learning module application process. Sometimes a GP will look at their credit point statement and they don't have the points for an activity that they've attended. If the activity was pre-approved for points, the organiser of that activity should have given you a certificate. Simply send a copy of that certificate through to the office and we can arrange to have those points on your credit point statement. If you don't have a copy of your certificate, you should get in touch with the provider and ask them to send one through to you. Rural GPs sometimes don't have as many options to face-to-face CPD as their metro counterparts. Remember to think about other Category 1 options that are not necessarily delivered by providers of GP education. Have a think about attaching to a local expert for upskilling and apply for Category 1 points through the supervised clinical attachment application process. Also think about getting together with other GPs and setting up a small group learning cycle. Once everybody's clocked in 8 hours, you can apply to have 40 Category 1 points allocated to your credit point statement. Don't forget about GP Learning. Members of the college have access to GP Learning, which is the college's online learning platform. Here we host over 200 CPD activities, including Category 1, all of which have been approved for CPD points. GPs who are delivering unsupervised obstetrics, surgery and anaesthetics may be eligible to access the Procedural Skills Training Grant. The grant is available for up to 10 days a year where a GP attends a grant-approved activity. Similarly, GPs who are offering emergency services may be able to access the emergency component of the grant. For more information on the PST and emergency medicine grant, GPs should contact the college's National Rural Faculty. Regularly look at your credit point statement to make sure that all your CPD points have been recorded. Try not to leave it to the end of the year. And of course, if you've got any questions about your CPD, please don't hesitate to get in touch with the WA faculty.
Thanks to Beth for that information. Let's head back to the studio now and that discussion with Dr. Paul Armstrong, Dr. David Smith and Olga Ward.
Could we come back to the influenza vaccine that we were just talking about before the break? 2010 flu vaccine, is that going to be protective?
That will be protective. The 2010 seasonal vaccine contains 3 strains, as it normally does. One of them is the H1n1 Pandemic strain, and we know that there hasn't been any significant change to that virus over the last year or so, so that should still be current and offer good protection. We have an H1n1 seasonal influenza strain. That's a strain that's been around for some years now, and also a B strain. And although in most parts of the world the H1n1 has been by far and away the predominant strain causing illness in the northern and southern hemisphere, there have been reports of influenza B being quite active in some parts of the world, especially Asia. So if people are feeling that their patients may be protected from just having the Panvax, the monovalent Panvax that came out last year, I think it would be more prudent to be offering them the seasonal vaccine and not resting on their laurels, as it were, because of that extra protection from the B strain. And we just can't predict what will happen this year, so it's better to be err on the side of caution there.
When would you, sorry?
Well, I was just going to comment also, with the elderly, we know that the highest risk is actually from the H3 strain, and that's continuing to circulate. And though that's been relatively stable, that virus changes as well. So it is important to get protection against that also. We've taken the previous H1 strain out of the vaccine now, because you can only really put one in. And some people have said, well, you know, what happens if the previous H1 strain comes back? Well, all the data so far from around the world looks like it's been replaced by the pandemic strain. There's very, very little of it. So we certainly don't anticipate that reappearing. It's you know, virtually all the pandemic H1 strain.
Yeah, I think the GPs are most concerned about the pandemic flu strain breeding with the normal wild infectious flu strain and producing something that's really infectious and really deadly. Yeah,
look, that's certainly been a concern, because influenza virus has its RNA in packets which are exchangeable, which is where you get reassortment. That's one of the important ways pandemic strains emerge, and indeed is the way that this one emerged. But it seems that once it's proven itself to be the human strain, or the new human strain, it doesn't do a lot of that anymore. It tends to just undergo the minor changes we see with seasonal strains. So we've had now these 2 strains circulating as it's been replaced, the previous seasonal strain and the pandemic strain, and we haven't seen any of those reassortments. We were worried because the previous seasonal H1 strain was nearly all resistant to Tamiflu, and it carries that mutation in the other important gene, the neuraminidase gene. So a bit worried, well, if it switched that gene with the pandemic strain, you'd end up with a pandemic strain that was resistant. But that hasn't happened. And with the way the seasonal strain is disappearing, it's really, really unlikely that would happen. but you can never be overconfident.
No, so are we expecting another pandemic in the next couple of years, or is this just something that will rear its head when it rears its head?
Well, pandemics are interesting. Just because we've had a pandemic last year doesn't lessen the chance that we're going to have a new pandemic next year. It's unlikely just because of chance, but pandemics over the last 300 years have varied in the time period between them from about 10 years to about 50 years. But that's not to say that there couldn't be 1 year or 2 years. So we go back to the beginning of the ledger.
Mm-hmm.
Yeah, and we know that there are regular events where, I mean, a pandemic occurs eventually when an influenza strain, which actually originates in bird populations, goes through this mixture of going into pigs and birds and humans and spits out a strain which is now infectious and transmissible.
Okay, so we need to blame the birds, not the piggies.
It's the birds, it's the pigs, it's the
bats,
it's horses, bats,
yeah.
Everything, you know. But exactly when those events are going to occur, we don't know. They're not predictable events.
Mm-hmm.
H5 is still around, continues to circulate, continues to infect people. So we know that virus has the ability to move from animals into humans. It just hasn't developed the ability to be easily transmissible between humans. But that's on the cards. A few years ago we had a different influenza A virus which caused an outbreak in veterinarians in the Netherlands.
Mm.
And that was another strain, it was an H7 strain. So we know these events are occurring, and exactly what makes one become the next pandemic we don't know, and therefore neither can we accurately predict when it might happen.
Yeah. Now, we gave out an awful lot of Tamiflu last year. Was there a particular reason for choosing Tamiflu?
Well, the two active drugs against influenza are Tamiflu or oseltamivir, or Relenza or zanamivir. And the reason that Tamiflu was the predominant one given out last year, even though there were in the national stockpiles, there were both of those drugs, Tamiflu being in a tablet form rather than in a capsule form rather than an inhaled form, is just much easier for most people to use, and that's the bulk of the stockpiles are Tamiflu, but there is some Relenza there.
Mm-hmm. Now, are there any other diseases that are threatening to become epidemics in human populations that you're kind of keeping a weather eye on at the moment?
Look, what we know is that, well, there are two challenges for Australia. One is that we're free of a number of diseases that circulate within our region, and therefore the potential for those to enter and establish themselves within Australia. There's been a particular concern related to the mosquito-borne viruses.
Yeah.
They're ones we know well, like Japanese encephalitis. In fact,
dengue's been in the news again.
Yeah, Japanese encephalitis is present in the Torres Strait Islands and has entered to the north of Queensland.
Mm-hmm.
So there's a concern about that. Dengue regularly enters into northern Queensland and causes outbreaks and then tends to disappear again through their very active eradication program they have here. But of course people bring it in again regularly. Mm-hmm. So we know that area is receptive, and potentially other areas of Australia could be.
So people are bringing the disease, or just the mosquitoes?
They bring the disease.
And then the local mozzies bite them and spread it around?
Yes, yeah. They have the particular mosquito Aedes aegypti present in northern Queensland. Most of the rest of Australia doesn't have it, fortunately, but it has the ability to spread to new areas. But what happens these days is, with the speed of air travel, people can move from one side of the world to the other while they're still incubating it and while they're still infectious. So that means they land and they're actually still infectious to mosquitoes that may bite them. If you come by ship, unless there were mosquitoes on the ship. But so that's one, is how we deal with the exotics that might come in and establish themselves in Australia. The second is new viruses or new infections that emerge worldwide. And there are about 1 to 2 new infectious agents emerge each year. And Southeast Asia is one of the hotspots for emergence. Mm-hmm. We all know, we've seen, well, the pandemic influenza, we've seen SARS emerge as a completely new human virus. We had the H5 virus emerge. We've had the emergence and spread of HIV over the last few decades, a recognition of hepatitis C. There are new enteroviruses which have spread around the world. There are a number of new bat-borne viruses, Hendrovirus, that many people would have heard about, and another one called Nipah. So these are regular events that are going to go on occurring, and as human populations get closer to the areas where these viruses may be circulating amongst animals, the more exposures we're going to see.
One of the viruses that we are keeping a close watch on is the chikungunya virus. It's an alpha virus in the same family as Retrieval virus and Barmah forest virus, and over the last few years now it's started to spread, and it's gone across the Pacific, across the Indian Ocean and into Southeast Asia and into Southern Asia as well. We don't have the mosquitoes here, we think, that can propagate that virus when it does arrive. And it does arrive. We get a couple of cases every month, 1 or 2 cases a month from travellers who are being infected. It hasn't established itself here, but we just have to keep a very close watch on that. We've made chikungunya a notifiable disease in 2007 as part of the surveillance and the monitoring of that virus. And in some places, although usually it's a self-limiting illness, although it can last for some months, a febrile illness with headache and lymphadenopathy and rash. In some places in Reunion Island in the Indian Ocean, it caused quite a number of deaths. So, you know, it has got the potential there to be quite a serious virus.
So again, these agents, infectious agents, are continually adapting to new environments and new ecological niches. So again, it's a matter of never trying not to be overconfident about what you think might happen.
Now, in my little general practice, I've seen a load of patients this year with diarrheal disease.
Oh, yeah.
How successful was the rotavirus vaccine, and what are we actually seeing at the moment?
Well, Paul can talk about the rotavirus vaccine campaign, and I'll talk about noroviruses after, if you like.
Yeah.
The rotavirus vaccine has been very successful, and there's been far fewer young children who are the main age group that get affected by rotavirus, far fewer cases in them, and also far fewer cases in their older brothers and sisters. So it has been a successful campaign.
So that's emptied out the infants' ward from rotavirus, and what have we filled it up with instead?
Well, in fact, I'd reiterate what Paul said. We've seen a dramatic reduction in the amount of rotavirus that we find now. I mean, if you look at the numbers, it's just so impressive how well it's controlled it's been. But what we did see about 5 years ago now was a change in this virus called norovirus. And norovirus is related to what we used to call Norwalk virus, and then Norwalk-like viruses.
Something that used to be called a small round virus?
Small round structured viruses,
oh, there
yes.
you go. Yes, I remember those.
Lots of names, because we didn't know much about it other than they caused outbreaks and what they looked like under the electron microscope. We now know a lot more about the viruses. But noroviruses have been around for, well, as long as we've been able to detect them. But it caused outbreaks, and quite limited outbreaks. The virus changed in Europe in late 2002, and a new strain appeared then, and they started seeing these large outbreaks due to this strain, and they gradually spread around the world, including Australia. And now the noroviruses are causing a lot of outbreaks of diarrhoea that occurs in institutional settings particularly, but also a lot of sporadic diarrhoea in the community. And we see it each winter, and then it's a bit like flu in one way, in that because people have had it, they get a partial immunity to it, but the virus changes due to their immune suppression. And when you get a new antigenic variant, we get a bigger season associated with it, and then it goes away again. The difference with norovirus is, well, one of the differences compared to rota is, whereas rota tended to be much more clustered towards the very young.
Yep.
You did see it in the elderly. Norovirus has a much broader age distribution, and in fact the largest burden we would see is outbreaks in nursing homes, hospitals, those sort of environments, affecting primarily the elderly.
So still just as hard to treat as the babies?
You can't, there's no specific treatment for it. It's good hygiene, and in institutional environment, lots of bleach.
But it's a very, very transmissible virus. That's another feature of norovirus, that it can just spread incredibly rapidly, and that's why we get outbreaks in institutions and with old people's homes, etc. And also as a pathogen in a lot of foodborne outbreaks. You might be a a gathering of people, and somebody might not have washed their hands as well as they might have, and most of the people there can become infected, or somebody vomits and in the corner
Everybody
that can spread around.
Mm.
So it's really a very infectious virus, and explosive spread is a feature of it.
Does the alcohol hand wipe stuff that people use, is that sufficiently protective?
No. Yes and no. It helps, but good hand washing, I think, in those circumstances is better. Now, soap and water doesn't kill the virus, but it gets rid of it off the skin. The alcohol washes would help used after hand washing.
Yeah.
But we know but the alcohol hand rubs are better than nothing. I was just going to comment on this bit about infectiousness. On average, a person with norovirus would have between 10 to the 12 and 10 to the 13 particles per gram of faeces. The infectious dose is about 100. So you can imagine that each gram of faeces contains 10 to the 10 infectious doses of norovirus. So you don't need much contamination to be able to spread infection.
Particularly in a nursing home.
Yeah, but really in any environment, but it all down to personal hygiene. It's all down to that.
Yeah. There's something else that causes mystification sometimes for rural GPs and for rural GPs who have patients who are hospitalised, and that's the detection of atypical mycobacteria in a patient who's produced a sputum sample for whatever reason, and we've thought, oh gosh, they've been sick for a long time, maybe we'll be clever and order AFBs, and then the jolly result comes back.
Yeah.
Is that a patient that would normally need isolating in the full TB protocol, or is this something quite different?
Look, it is quite different. The atypicals are called atypicals because they're not TB and they don't behave in the same way. They're largely environmental mycobacteria which get into the lungs occasionally, but they are usually significant only in people who have pre-existing lung disease. Either they have chronic bronchitis, they have pre-existing cavities due to bronchiectasis or something like that, and that allows them to colonise and establish in those people. Even in them, whether they're causing an actual disease can take a little bit of work to figure out. What we do know is, unlike TB, where if somebody has TB, basically everybody around them is susceptible.
Yeah.
With the atypicals, it's not the case. You don't get the amount of shedding. The vast majority of us were exposed to them anyhow. They don't cause us any problem at all. There are two difficult times. The first is when the person first comes in and you suspect they might have tuberculosis, or you've got that first thing that says they've got AFBs and you don't know what it is.
Yeah.
Then you've got to make some sort of clinical judgment. But if it might be tuberculosis and they're coughing up AFBs, then they need to be isolated until it's sorted out. With the modern molecular tests, it's pretty quick to sort out. If they have AFBs on a ZN stain, then it's another day and you can sort out whether it's going to be TB or an atypical. But until you know that, you've got to be cautious. Some patients, not a problem. You know, they've got chronic chest disease, you've got a few AFBs, they've really not got any risk of TB, they don't have any cavities, they don't have anything that suggests that they're not actually very sick. You can be more confident. But if you're not sure, you put them in, wait for the test results.
Just as well, because they're no end of a pain to eradicate.
You're absolutely right. Much more, in many ways, more difficult to treat if you have to.
And while we're talking about hospitals, could we talk about community-acquired and, I guess, small rural hospital-acquired, which is probably community-acquired MRSA? How do we deal with that in a rural setting?
Well, you want to comment on the current epidemiology?
Yeah, sure. We need to think about MRSA as hospital strains and community-acquired strains, and there's some overlap there, but it's important to keep them a little bit separate. And over the last 3 or so decades, there has been an emergence of community-acquired MRSA strains of various types. Some of them have a particular virulence about them which causes much more severe disease, deep-seated myositis and abscesses and furuncles and the whole gamut of disease caused by Staph aureus. And there's a gene called the Panton-Valentine leukocidin gene, which is often or let's call it PVL. That's what
I
it's
can't
called.
wait to say that one to my patients.
And those are the ones that we are really chasing hard at the moment. In a way, two years ago, we introduced a policy around Western Australia to search and destroy for these particular strains that were coming through. And with the very high public health resource need to chase these people up, with the advent of or the swine flu that came on board, and everybody was just flat chat with that, and probably just due to the natural history of the way these things are spread, we've had to pull back the defences. And importantly, we're changing the policy now, and it'll be much more of a focus in trying to get rid of these particularly virulent strains in the world of GP, with some public health support. But what we will be going towards, and we do this already in a way, is to, whenever we get a sample that we know is in one of these nasty categories, we'll be writing to the GP with a recommendation on treating the person first, if they're not already treated, and then trying to eradicate that particular, decolonise the patient.
Okay, now that sounds complicated. So you start off just with your normal antibiotics that you would when you think it's a normal staph, and then you find it's an MRSA, and we get a phone call or a letter from one of you guys that says, try this fancy antibiotic, and then decolonise the patient.
Yes, well, unfortunately there's a couple of weeks wait between when we get the strain isolated or the Staph aureus recognised.
Yeah.
And then by the time we know that it's from one of these nasty categories, it's a couple of weeks. And at that stage, public health authorities will be sending out letters to the GP who ordered that test, saying, you've got a nasty one here, make sure your patient's treated, here's some advice on treatment. And after treatment, then we recommend that the patient gets decolonised. So that's a combination of daily 1% triclosan body washes, and twice daily mupirocin ointment in the nose. If the patient does develop those, similar sort of lesions again, and to use the particular antibiotics that are designed for community-acquired MRSA, not the standard Staph aureus, the methicillin-sensitive Staph aureus medications. So to keep a high alert that this patient may not be decolonised if they get lesions again, to treat them as if it's community-acquired MRSA again.
Yeah. All right, and just finally with that strain before we finish, would you then also eradicate in the family of the patient as well? Do you go swabbing?
That's...
Well, it depends a little, not normally, because it's a little difficult to know where you end.
Yep.
It's a problem if your decolonisation fails and you think people are recolonising, looking for potential sources for them. But generally decolonisations work.
Yep.
And so you worry about if they don't.
Mm-hmm.
There was one other aspect I did want to talk about with this, which is when you treat a person as having an MRSA.
Yep.
And I think that's important because we know that the community MRSAs have become more common, but we also know the vast majority of our Staph aureus is still susceptible to flucloxacillin. So I think as a general rule, we would still rely on flucloxacillin as our primary therapy for what proven or suspected staph infections, unless they're shown to be resistant or unless they're clinically failing to respond. However, I do think in patients who are moderately to severely ill, particularly those who have a lot of comorbidities, you do want to think about whether you've got enough room to try these, and if they don't work, you'll change to something else. And in those cases, you do want to think about whether first up you're going to cover your community strains and then community MRSA strains, and then pull back from that if it turns out to be susceptible. Mm-hmm. And that does mean either using something like vancomycin as an intravenous drug, or a lot of them are actually susceptible to oral clindamycin, which is very well absorbed orally as well. And you can look at adding that to your flucloxacillin as a bit of extra cover.
Okay, so clindamycin, which of course is available in country hospitals, whereas vancomycin quite hard to get hold of.
Well, yes, yes, I know.
I'm sorry. Thank you so much for joining us today. That's all we've got time for. and that's been a most useful program.
Thank you very much.
And thanks very much to Dr. Paul Armstrong and Dr. David Smith for taking the time to come and talk with us. Finally tonight, we had an opportunity to talk to Dr. Mike Eaton, the WA Director of the Australian College of Rural and Remote Medicine, about some other educational resources that are available online through ACRRM's website.
ACRRM's CPD program is designed to provide rural doctors with the maintenance and upskilling that they need to practice safely in rural areas and in the metropolitan area. The website contains full details of all the previously registered activities, including those that are coming up, and also includes information about who to contact, how to register, and what the costs are, if any. All the activities that are currently on the Romeo website will be already accredited for CPD points, and so once you've attended and signed the course or participated and shown that you've been there, then your points will automatically be allocated. If you're planning another activity that hasn't been organised by a group or that isn't registered on the website, in other words, something you're planning just yourself, whether it's in Australia or overseas, then I suggest that you contact the CPD committee directly and get prior approval. And that's as simple as calling them on the 1-800 number that's on the ACRRM website. It's 1-800-223-226 and ask for the CPD program coordinator. And usually you'll get through very quickly and be able to get an answer quickly as well. Your CPD statement is there online. You can actually see how many of your accumulated points you have and in the categories that you've accumulated them. And particularly if you're a proceduralist and you need brownie points for anaesthetics or for obstetrics or general surgery, and for emergency medicine, you'll find that these points are separated out on your statement, and you can easily check online at any time how many points you've got or how many you need to satisfy the curriculum requirements. If you realise that you're down on a given area, and particularly if it's an essential area such as your advanced life support or some MOPS points for your specialty area, procedural area, then you can access online a list of all the available courses across Australia, and there are many thousands of those that are available during the triennium. If you're joining an activity that's run by another college, for example the College of Surgeons or the College of Anaesthetists, College of O&G or even the College of GPs, then those activities can be lodged with ACRRM PDP for points. It's better if the college has already applied for accreditation for that activity, but if it hasn't, what you need to do is keep a record of the course content and the dates and of your attendance, in other words an attendance certificate or something to that effect, and then you send those in to the PDP department, who will then assess their value for points and give the points that you have accumulated. Another feature of ACRRM PDP is that all members have access to the clinical guidelines, and these are a really, really useful form of a summary of all the major clinical activities, the emergency activities in particular, that you need to have available for you in rural practice. And these clinical guidelines are now available for iPhone, BlackBerry, for PDA, for Palm Pilot, for a whole range of different applications that are handheld. I use these regularly in remote and rural clinical practice and find them invaluable as a backup for what you might be thinking of but not really sure. And if you're not comfortable about ringing a colleague in the middle of the night, they can be a really useful resource to have a look. And they're updated constantly in about a dozen different areas now. And so they're very, very useful and succinct. Their aim is to have the information available that you need within 90 seconds of opening the application. And that's generally held to form. It's very, very quick to find what you need. So if there's anything more you need to know about the ACRRM PDP program, all you need to do is check up on the website or give a free call to 1-800-223-226 and ask for the PDP program. If you haven't been participating in ACRRM's PDP program yet, you'll be surprised at how flexible it is and how oriented it is towards your needs and helping you to achieve the learning that you want to make your practice safer and more satisfying.
Well, that's just about it for this broadcast. A big thank you once again to everybody involved in tonight's program. Now, don't forget that if you'd like to review this program or any previous program from last year, you can watch them online or download them as a video or audio podcast via the Rural Health West website at www.ruralhealthwest.com.au. We'll be back again on the 4th of May, where we take a closer look at some of the fancier tests and procedures that are now available across a wide range of medical disciplines. Thank you for taking the time to join us, and good night.